Okay, I can now verify that the recording is starting.
Okay, just to notify everyone, this meeting is being recorded. Agenda item number 2, disclosure of any conflicts of interest. Please disclose any conflicts of interest that you have at this time. Is there anyone with their hand up?
No.
Then we will go on. But before I go on to the next agenda, roll call, I'd like to introduce the new member, Nam Phan. Hello. From CareSource, and I'd like to give you a second to introduce yourself and provide a brief introduction.
Sure. Thank you for that opportunity, Doctor. So my name is Nam Phan. I am the Chief Operating Officer over at CareSource. We're the nonprofit that just went live on January 1st with the statewide contract. Prior to my time with CareSource, I spent 15 years at another MCO where I oversaw all the government lines of business. And so that was everything end to end, like claims, customer service, membership, all the way to like audit, compliance, finance, all that good stuff. I really enjoyed my time there, really enjoyed the work that I do. And then prior to my time with that NCO, I spent several years as an assistant district attorney. So I really enjoy the work that we do as a nonprofit because the work that I saw when I was a district attorney focused on a lot of the indigenous folks, right? So related to that, and I'll get into that a little bit later. I just want to keep it short and simple, but very excited to be here. Very excited on behalf of CareSource to be on this committee and hoping that we get to do a lot of good for our Nevada members.
Welcome.
Thank you.
Welcome. Thank you. With that, we are moving right along to agenda item 3, the roll call. And I'm going to go ahead and call everyone's name and either raise your hand or issue the initiative, the affirmative if you're here. Administrator Ann Jensen. John Phoenix.
Here.
Don Lyons.
I'm here.
Thank you. Dr. Todd Gray. Darren Austin Moffitt.
Here.
Here as well. Desiree Gomez.
Here.
Thank you. Casey Melvin.
Present.
Thank you. Shauna DeRoos.
Here.
Thank you. David Escamay.
Here.
Thank you. Kim Gagan.
Here.
Thank you. Sarah Fox. Ann Phan.
Here.
Thank you. Bill Sims.
Here.
Thank you. Azraella Gravel.
Azraella is present.
Elani Queen.
Present.
Thank you. Grace Larkins.
Present.
Thank you. Sarah Dearborn.
Present.
Thank you. Robert Thompson.
Present.
Thank you. Rick Robb. Kimberly Abbott.
Present.
Thank you. Jonathan, have we met before?
I just want to verify, I think I saw Sarah wants to join online. Sarah, can you confirm if you're online?
She's put that she's in the chat.
Oh,
Thank you.
yeah, yes, no, it may well get me forward.
Excellent. All right. And then we go on to agenda item 4, public comment. So if you would like to make a public comment, please raise your hand or type public comment in the chat or the last 4 digits of your phone number and your name will be called on to begin. So please state your first name, your last name at the beginning for recording purposes. You will have 3 minutes to speak. And Jonathan, you're going to let us know if there's any public comments.
Yeah, we do have some already. Few people have their hand raised. I'll just call them. John Phoenix.
Hi, John Phoenix. Actually, I'm a member of the committee, but I wanted to make a public comment since this is not an agenda item. My comments today are to formally request that this committee examine the current policy on treatment of hepatitis C as recently released in the Medicaid guidelines and pharmacy benefit manager protocols effective January 2026 by adding this as an agenda item at a future meeting for this committee. I'm specifically asking that in the interest of patient access and treatment success, that this committee requests an exemption to the specialist consultation requirement for direct acting antiretroviral or DAA treatments of chronic hepatitis C virus infection for the above referenced individuals, as outlined in the Nevada Medicaid anti-hepatitis agents coverage criteria. Who represents the margin? I represent the voice of marginalized communities as a provider, and that's how I am making this request. These are the substance use communities, the mental health community, the community living with HIV, our communities with color, and other marginalized communities. Under current Nevada Medicaid policy, medications such as Epclusa or Mavorite must be prescribed in consultation with a hepatologist, gastroenterologist, infectious disease specialist, or HIV specialist. My request is based on current nationally recognized clinical guidelines and the patient's clinical eligibility for simplified hepatitis C treatment, which does not require specialist involvement. The clinical justification for this is that the American Association of the Study of Liver Diseases and the Infectious Disease Society of America jointly recommend universal treatment for all persons with acute or chronic hepatitis C infection, except those with a short life expectancy that cannot be remediated by hepatitis C therapy, liver transplantation, or direct treatment. The 2023 AASLD and IDSA hepatitis C guidelines specifically emphasize expanded access to treatment through simplified treatment algorithms designed for use by non-specialist clinicians, including primary care physicians. According to these guidelines, treatment-naive adults without cirrhosis or without compensated cirrhosis are eligible for simplified treatment pathways using pan-genotypic direct-acting antiretrovirals or antiviral regimens such as Epclusa and Mavorite. These regimes have demonstrated sustained virologic response exceeding 90%, 95%, and outcomes comparable to specialist management care. The patients need to meet all of the required other hepatitis C treatment guidelines, but based on national clinical guidance, the patients do not require necessarily to see specialists in consultation for the majority of their treatment care. Nevada continues to face significant geographic and workforce limitations in access to hepatology, gastroenterology, and infectious disease specialists, requiring specialty consultation for patients who qualify for simplified treatment creates unnecessary delays, administrative burdens, and barriers to care, and is inconsistent with national hepatitis C elimination goals endorsed by the CDC and the U.S. Department of Health and Human Services. Given the patient's otherwise eligibility under evidence-based national guidelines and the absence of clinical indications requiring specialty management, I respectfully request that there be exemptions listed to the specialist consultation requirement and authorizations to initiate Epclusa or other hepatitis C treatments under a simplified treatment protocol consistent with the AASLD and IDSA recommendations. Thank you.
Thank you, Madam. Thanks, we made for that as a potential future agenda item. Moving on to the next candidate, Lady Shannon.
Good morning, Shannon Sullivan Figueroa. Or good afternoon. Thank you for the opportunity to make public comment. My name is Shannon Sullivan Figueroa. I am a speech language pathologist and pediatric private practice owner in Northern Nevada. I also serve as the secretary for the Nevada Speech Language Hearing Association, or NSHA. NSHA is making a public comment to continue advocating for speech swallowing codes that are not being reimbursed through the Nevada Medicaid for provider type 34 for therapy. NSHA has been working on these codes since 2023. We are happy to provide previous comments and communication that has been submitted to Medicaid for both NSHA, from both NSHA and ASHA, the American Speech Language Hearing Association. The following CPT codes are currently not included in the provider type 34 fee schedule. 92612, flexible fiber optic endoscopic evaluation of swallowing or fees. 92511, nasopharyngoscopy with endoscope. And 31579, diagnostic laryngoscopy with stroboscopy. These codes are included in the provider type 20 physician fee schedule. NISHA members have reported that physicians in Southern and Northern Nevada are not completing these procedures, which is presenting a barrier to care. This work is within the scope of practice for speech language pathologists, and private insurance reimburses SLPs for these services. NISHA is also continuing advocacy for Medicaid pay parity between provider type 34 and provider type 20 and 60. Codes across speech language, occupational, and physical therapy under provider type 34 are reimbursed on average 10 to 15% lower than the exact same codes in the provider type 20 and provider type 60 fee schedules. For example, 92507 is reimbursed at $73.76 for providers type 20 and 60 and is $63.64 for provider type 34. Provider type 60 covers school-based services. Providers who perform services in the community versus in a school setting should be reimbursed with parity, as the training and degree required and care provided are similar, if not more skilled, in the private practice setting. Gaining pay parity would increase access to services across the state. Insight and guidance on future steps we should take to make these changes would be helpful. We are happy to provide any additional information and resources and look forward to hearing how we can continue to advocate for these changes. Thank you for your time.
Thank you, Shannon. I do not see any other hands raised online, although we have one in the room.
Hello, my name is Azraella Gravel. I'm Vice Chair of the MAC Council. I would just like to summarize our meeting earlier this morning. Director Jensen went over managed care contracts, 37 legislative bills passed, and the fiscal impact on the kids' behavioral health from the HR1 bill that the current federal administration has passed. Members should see federal changes to the HR1 guidance this June. The 2030 budget cycle will see these fiscal effects. Moreover, there was an expansion of Medicaid to adults without children to 250,000 Nevadans, which make up 1/3 of our population. Their annual renewal will be every 6 months with a community engagement checklist. Our members discussed prior authorization for providers, single prescription lists for all 5 managed care organizations, including pay for fee services with delivery systems updated. The DWSS has been updated to DSS, or the Division of Supportive Services. Members discussed the Project Online system eligibility with Medicaid's Exchange website. Members evaluated standards on the current Medicaid satisfaction survey and intend to work on a beneficiary satisfaction survey for June's BAC meeting. Furthermore, members brought an agenda item to update the automated voice messaging response system to omit COVID regulations for the DSS call center. The grievance systems program already exists for the 5 managed care organizations, and the fee-for-service Medicaid is being developed with a grievance policy to be clarified in future meetings. Finally, the BAC work plan was approved with added edits during the meeting. Thank you.
Seeing no other hands raised.
Excellent. We're going to move on to agenda items 5 and 6, which is the discussion of the November minutes and vote on the meeting minutes. So the meeting minutes were sent to the council members on December 11th, 2025 via email for review. Are there any discussion, clarification, or comments on the minutes at this time? Yes.
There's a quick edit. There's an H on my name. That's all. Or Sarah Dearborn.
Let's correct that, please. Any other comments? If there is no discussion, and I see no discussion, I'd like to call for a motion to approve. And motion, second?
Second.
This is John Phoenix, I second.
Okay, excellent. So now I'd like to ask for any votes in the affirmative. Do I hear? Aye.
Aye.
Any nays?
Aye.
And any nays? Hearing none, the motion passes.
With the
With the changes mentioned.
Thank you.
And with that, what I'd like to do is Casey Melvin, who is the vice chair, and I will be tag teaming the rest of this one by one. So Casey, will you take agenda item 7, please?
Absolutely. Next up, I would like to introduce the administrator for the Division of Nevada Medicaid, Ann Jensen, to provide her administrator's report.
Thank you, Casey, and thank you all. So I'm able to see everyone here today. For those that haven't met, I'm Ann Jensen, and I'm the director here. So first, I want to express my gratitude for you all taking time out of your busy days and busy lives to be here. I appreciate this is a lengthy meeting, but it's one of my favorites that I ever get to go to each quarter. It's an honor just to get to hear directly from you all on how our program is going, to provide some updates, and to get your feedback on things that we can continue to do to serve patients and support our providers. So first and foremost, thank you all for being here. As always, in my administrator's report, I provide a kind of high-level overview on what's most important and what we're focused on in the Division of Nevada Medicaid. So what you'll continue to hear, and I appreciate the patience of folks that were on our back meeting this morning, you'll hear very similar updates, but that repetition is important because those things remain our top priority and really are complicated issues. So I will touch on each quarter, not only the high-level category, but more specifically what we're working on at that time within it. And I'm happy to take any questions on these as we go. So at a high level, those 3 items are going to be number 1, continued implementation of our new managed care contracts. Number 2, legislative implementation of state and federal regulation and new state and federal regulation and ongoing guidance. And then number 3 is our children's behavioral health transformation. So again, at a high level, those feel quite familiar, but I'll walk through each to share kind of where we're at, what's happened since our last meeting, and where we're looking moving forward. So firstly, I think context on these new managed care contracts is important. So Nevada has had managed care in our state for a significant period of time. This again is a delivery system, meaning a mechanism that states can use to pay for a Medicaid program and adjudicate the way that that Medicaid program is designed. We go through the process in Nevada about every 5 years to offer a new contract period to our managed care partners. And so our new contract term started January 1st of 2026 and will last for 5 years, which gets us into the 2030s, which is kind of hard to believe, but we'll be here before we know it. So this new contract term and during as part of that process, the state has an opportunity to really evaluate what are our priorities and how do we reflect feedback and learnings from the community in that new contract. So that's a typically 1.5 to 2 year process to procure new or existing bidders, folks that are interested in being a managed care program or partnering with us here in our state. So that began back in 2024 in preparation for January 1st, 2026. So I just want to acknowledge first and foremost our team that worked incredibly hard during those 2 years to prepare for this, to support with our managed care partners. I want to thank them for all their hard work during implementation. It was an incredibly successful launch. The state feels it was really successful and as smooth as possible given the breadth of the changes. We're really grateful to everyone's quick work and support to address any road bumps that came up or any questions that folks had. But generally, we feel really proud of the way this is run, and we'll continue to keep a close eye on this as we move forward. What's important is every contract looks a little bit different. And so this year in Nevada, managed care contracts look different in a number of ways. Firstly, and probably what's most top of mind for folks here, is we expanded the geographic scope of managed care. So now our managed care products, meaning health plans that we contract with, are available in every single county in our state. So we have 2 managed care partners in our rural and frontier communities, CareSource and Silver Summit. We have 4 partners in Washoe County. So in addition to those 2, we include Molina and Anthem Blue Cross Blue Shield. And then in Clark County, we have the addition of a 5th health plan, which is United Healthcare Health Plan of Nevada. So those 5 partners are part of what our next 5-year contract term will look like. And so I want to thank each of them for their hard work and implementation. And as part of their contract with the state, we have set the terms through that contract through our procurement process. And so not only is the geographic scope different, but there's a couple of other things that we changed. We also we changed the way that provider rates are set. So we talked about this in our back meeting. This gets wonky pretty fast, but I know is near and dear to many providers on this call's heart, but it's important to know we have directed our managed care partners through our contract to meet or exceed the payment rates that the state has on the fee-for-service schedule. This is, as all policies are, includes some nuance and there's some exceptions that but generally, our fee-for-service fee schedule, the state's fee schedule, is the minimum payment rate that our managed care partners use when negotiating contract rates with physicians. So that's a difference, that's a change in this contract period. Another change is our single preferred drug list. So we'll talk about this. Antonio, I'm excited for him to share a little bit more about what that looks like. But at a high level, it aligns all 5 of our MCOs and the state's preferred drug list to have a little bit more seamless experience for providers when determining what drugs are preferred and covered by the Medicaid program, and also for members who may be switching between plans or moving across the state. The way that their prescriptions are covered is consistent across all plans. So that was another one of the changes that we made as part of the contract. So there's a range of things that we added, and I won't get into all of them. I just want to acknowledge, we talk a lot about statewide managed care and the expansion, but a new contract period affords us a chance to look at all of our managed care program. And it's more than just a geographic piece. And so we recognize those are some of the changes that our members and providers and managed care partners are all working through at this time. So I just wanted to acknowledge what those are. This will remain a top area of focus for us throughout the year, just because go live has happened and we're in a more kind of normal or consistent pattern with that. Doesn't mean this doesn't maintain a top priority for us, and I know for our managed care partners as well. So I want to thank everyone. I want to give a special shout out to our district office member services team. They field calls from our members, and they had 3 times the normal call volume in the month of January, including 3,000 calls in the first week alone, because a lot of people had questions about their new benefits, their new card, and how that interacts with all their care. So just want to thank them. They're absolute powerhouse and just approach each of these calls full of care and patience, and I'm really grateful for that. So I'll pause there on our new contracts. We'll talk about this throughout. We have a discussion item related to statewide managed care, so I'll hold any questions until that period, but just want you all to hear where we're at. Number 2, as I mentioned, legislative implementation. So excited for agenda item number 8 to cover state legislative updates. There's 37 bills we're in the process of implementing. We're about 52%, I think, so far, which is great. Those have effective dates that range from the moment they were signed by the governor to 2030. So this is going to be an ongoing process. But of course, while we're still working on last session, we're preparing for the next. So we're beginning our work to develop our state requested budget that goes into the governor's requested budget that will be shared publicly in early 2027 before session begins. So we have our hands in multiple worlds. Past session, a couple sessions before that, even for some bills that we're still implementing, and then already, of course, looking ahead to the next. As I shared with the back, that means, importantly, Nevada budgets on a 2-year cycle. So what we're making decisions on right now as a whole team is, what do we anticipate needing funding and resources for all the way into 2029? And for many of us that are familiar with budgeting and projecting finances, that's a pretty far way to go, but it's the reality of our budget process. And so we're having a lot of conversations about how to ensure that we're preparing for that time appropriately. Which leads us into my second component of legislative work, which is the federal side. So as we've talked about in this meeting this quarter, there's pretty significant federal legislation that was passed in July of 2025, all my years, 2025 last year. The One Big Beautiful Bill Act, I call it HR1 just because it's easier than all the B's, but there's a lot of work there that impacts both on the fiscal component of some of our revenue generating programs, as well as importantly on the eligibility side. So there's a lot of work that will go into effect beginning January of 2027, which will be here before we know it, related to specifically the adult expansion population. As Azraella mentioned, we're trying to be really clear in how we talk about this because there's a lot of national media questions, concern related to these changes, which I really appreciate. And so we want to be really clear on who this applies to. Specifically, our adult expansion population is the one for whom the changes to how frequently their Medicaid redetermination occurs, as well as their community engagement requirements. So that means that come January, when folks will need to attest that they are working, volunteering, or attending school in a way that meets federal requirements. There are many exceptions for folks that do not have to meet those requirements related to chronic conditions, identity as a tribal member, identity as a caregiver, things like that. There's a lot of nuance and complexity there. So we're holding our first public workshop on how Nevada will be defining this on our third week of March. I gave the wrong date to our first meeting, so I'm not going to say a date and get it wrong this time, but I promise it will be on our public notices page and our website. We'll be kind of reviewing what guidance we've gotten from our federal partners to date on this, what decisions we need to make as a state in terms of the flexibility we have to define a few components of this program. And then we will continue to have these public workshops as we prepare to start patient communication and notification of this process late summer, early fall. So we welcome all MAC members to join us in those public workshops. I would recommend, I know we'll be talking about future discussion items for upcoming meeting topics, but I would love for this to be an ongoing topic for this committee. Really to ensure that the way we're communicating with our members and with our providers is really clear and helps folks understand what changes are happening and where action may be needed. So a lot of work on that front, also acknowledging there's a lot of this that's still evolving with guidance from CMS, our federal partners here. I had a call with them during our lunch break on a different part of the HR1 regulation, and they're waiting on federal rulemaking just as much as we are. So there's a lot of things that are changing quickly. And if you all ever have any questions on this, I'm more than happy to hop on a call or talk through them, but we look forward to these public workshops to get into those details. Last item, as I mentioned, kids' behavioral health. This remains near and dear to our work and will be a top priority for us for years down the line. What I'm excited for this quarter is that we are going through a procurement process, kind of like what I mentioned for the mainstream managed care products, for a specialty health plan. And that specialty health plan will be designed uniquely to serve the needs of kids in foster care and kids with behavioral health needs, some more significant behavioral health needs. That plan will go live on July 1st of 2027, so next summer. And since we last met, we made a couple program changes that include taking a similar approach to what we did for mainstream managed care, which is geographically scaling our approach to this project. So we will start that summer. The first 18 months of the plan will be specific to urban Washoe and Clark counties to ensure that we can really test the pilot and make sure that we're responding quickly to feedback and iterating on it. And then in partnership with the selected bidder, we'll scale statewide to serve all communities in our state. That doesn't mean we won't be supporting kids and families and providers in our rural communities in the meantime. In fact, we're designing a lot of the rates to be specially designed to incentivize care delivered in rural communities. But we're also going to be going to the legislature in April to ask for additional resources to support our rural communities in that interim, to provide more robust care coordination on behalf of the state for these kids, to make sure that they're getting access to all the resources they need, and we're supporting our providers and billing Medicaid in the meantime. So a lot of detail there. As always, welcome folks to attend our kids' behavioral health working groups. I know you have a million working groups on your list, but if you're interested in getting deeper on these topics, we meet every other month for 90 minutes and bring policy topics and other items to share with the group, and would welcome your feedback on them. So with that, I know that's a lot of talking at you all, but I hope a helpful way to get a summary of what's important in our world and what we're focused on. Would welcome any questions if folks have them now. Again, I'll ask on the statewide managed care piece. We'll save that to item 11 just to keep things organized that way. But anything else, very happy to answer questions.
Excellent. Hearing none.
Are there any online from our members?
I'm going to go on to agenda item number 8, which is legislative updates. At this point, I'd like to introduce Kimberly Smalley, Social Services Chief with the Division of Nevada Medicaid, to provide legislative updates.
Thank you. Good afternoon. I am filling in for Casey Angris, who is unfortunately unable to join us today. I am going to be walking through several of our Medicaid-related state bills and giving a very brief overview of the bills and where Nevada Medicaid is with implementation. Starting with, next slide, please. Thank you. Assembly Bill 36. This bill requires Medicaid providers to submit a request for fair hearing within 90 calendar days of an action, unless they can show there were special circumstances that would prevent that. This timeline currently exists in Medicaid policy, but is now formally part of Nevada state law. AB 36 was effective January 1st, 2026. And Nevada Medicaid is currently drafting policy that will define what qualifies as an extenuating circumstance. And this policy change will be adopted at an upcoming Nevada Medicaid public hearing. Next slide, please. Thank you. Assembly Bill 42 shortens the time frame for Nevada Medicaid to provide notice of adopting, amending, or repealing a regulation or policy from 30 business days down to 3 business days if the change expands services or is required to comply with federal or state law. This bill also changes allows changes to be retroactive if it is required to comply with federal or state law, and the notice clearly states it will be applied retroactively. AB 42 was effective May 28th, 2025, and has been fully implemented. Next slide, please. Thank you. Assembly Bill 315. This bill requires that all providers submitting an application to participate as a Medicaid provider must have notarization or have their identity verified through an electronic identity verification system used or approved by the Nevada Health Authority. AB 315 was effective July 1st, 2025, and has been fully implemented. Assembly Bill 556 renames the Medical Care Advisory Committee to the Medicaid Advisory Committee, MAC, and updates the MAC membership structure, compensation rules, and adds access to services as an area of focus. This bill also creates the Beneficiary Advisory Council, or BAC, which will advise the MAC on development of policy concerning Medicaid with a focus on the experience of Medicaid beneficiaries in relation to Medicaid quality, access, and equity. AB 556 was effective January 1st, 2026, and has also been fully implemented. Senate Bill 9 updates Nevada Medicaid's third-party liability rules to align with federal requirements. When Medicaid beneficiaries have additional healthcare coverage, third-party liability rules govern the legal obligation of third-party payers. Updates are being proposed to reflect revisions to Section 202 of the Federal Consolidated Appropriations Act of 2022, which changed 2 requirements to include the pursuit of recoveries associated with commercial insurance if they are the primary payer, and it also includes the requirement for any insurance carrier third-party payer to respond to a state inquiry associated with recoveries within 60 days. SB 9 was effective July 1st, 2025. Nevada Medicaid is in the process of making changes to the Medicaid Services Manual, Chapter 100, and drafting a state plan amendment for federal approval. Next is Senate Bill 54. This bill directs Medicaid, when federal funding is available, to cover medical respite services for individuals experiencing homelessness. This includes acute and post-acute medical care and other services. The effective date for SB 54 is July 1st, 2027. Nevada Medicaid is currently working with a vendor to develop an application for an 1115 demonstration waiver amendment that must be approved by the federal government. The application will be made available to the public for a formal comment period once it has been drafted. Senate Bill 138. This bill requires hospitals that provide birthing services to enroll as a qualified provider to decide if a pregnant individual can receive Medicaid. These hospitals and their partners must provide certain Medicaid notices. Parents and legal guardians of babies in the neonatal intensive care unit must be given specific rights to help care for their newborns. The effective date for SB 138 is January 1st, 2026. Nevada Medicaid has submitted a state plan amendment that is currently pending federal approval. Senate Bill 165 requires that Nevada Medicaid cover behavioral health promotion and prevention services provided by a behavioral health and wellness practitioner. The effective date for this bill is January 1st, 2026. Medicaid already covers the services of behavioral health promotion and prevention through prevention and intervention strategies like screening and rehabilitative services. The Board of Psychological Examiners has scheduled a public workshop for March 6, 2026, where they will review the certification requirements for this new type of healthcare professional. Once the certification for behavioral health and wellness practitioners is created and the associated curriculum is delivered, Medicaid would anticipate more providers enrolled as qualified mental health associates with this certification. Finally, we have Senate Bill 353, which requires the Nevada Medicaid Agency to set up a new billing category and daily reimbursement rates for university-run behavioral health training clinics that train future behavioral health professionals. SB 353 has an effective date of October 1st, 2025, and Nevada Medicaid has submitted a state plan amendment that is currently pending federal approval. This slide contains some links of the resources that are available for keeping updated on Nevada Medicaid's legislative implementation and initiatives. And that wraps up the legislative updates. As you can see, several of our bills are already in place while others are moving through policy development and federal approval. We appreciate your engagement in this process and welcome any questions.
Thank you. Hearing no questions, I'm going to turn it over to Casey for the next.
Perfect. Moving on to agenda item number 9, we will introduce Dr. Keith Benson, the State Dental Health Officer, to provide their update regarding the 1115 waiver and adult dental. After his presentation, we will leave time for feedback and questions.
Good afternoon. My name is Dr. Keith Benson, and I'm the Nevada State Dental Health Officer. And I would like to first start by thanking this committee for allowing me to complete our post-award forum for our 1115 demonstration waiver titled The Whole Mouth, Whole Body Connection for Adults with Diabetes. This meeting helps us satisfy the federal requirement Title 42 within 6 months after the implementation date of the demonstration, and annually thereafter, the state must hold a public forum to solicit comments on the progress of the demonstration project. This demonstration waiver was approved by CMS July 1st of 2024 and is good through June 30th of 2029. Can we do the next slide, please? This is just a quick little agenda of what I'm going to be covering today. I promise I will make this brief. Just kind of giving an overview of our waiver and some of the neat little parts about it. Let's do the next slide. So just a quick overview. Section 1115 of the Social Security Act gives the Secretary of Health and Human Services authority to approve experimental, pilot, or, as in our case, demonstration projects. These demonstrations give states additional flexibility to design and improve their programs. Our 1115 waiver is hoping to demonstrate the impact that more extensive dental benefits have on A1C scores of diabetics, eligible Medicaid adults. By providing expanded dental benefits to diabetic adult members and treating more advanced gum disease and other sources of dental infections and inflammation, we're hoping to show the causation between these treatments with a reduction in A1C results. Can we go to the next slide, please? So unfortunately, the 1115 additional dental benefits are not available to all Medicaid enrolled adults. And I'll kind of go through how eligibility is determined. We determine eligibility from claims data. And so what we're doing is a multi-sorting process where first we go through claims and we're looking for specific ICD-10 diabetic diagnosis codes in claims data. We're then verifying those members are still enrolled in Nevada Medicaid. And then we're also looking for claims from participating FQHC and tribal health clinics for ages 21 through 64. We're providing an actual mailed letter to those members when they're determined to be eligible, as well as providing quarterly updated eligibility lists to those participating clinics. Can we go to the next slide, please? And so the partners that are participating are two federally qualified health centers, Nevada Health Centers, who have an FQHC that has dental services in both Las Vegas and Elko, Nevada, as well as Community Health Alliance, which is located in Reno. We are also able to add 8 tribal health clinics that are listed below. Can we go to the next slide, please? And I'd like to take a moment to recognize the following partners who have completed seen patients and have gone through this new reimbursement program for this 1115 waiver. Those include Pyramid Lake Tribal Health Clinic, Walker River Tribal Health Clinic, and Nevada Health Centers, both in Elko and Las Vegas. Additionally, Fallon Tribal Health Center and Las Vegas Paiute Tribe have also started providing services. And so that's about half of our participating clinics. And so we're working with Gainwell to help them with billing. And we've done a few presentations, but we're looking forward to completing some more to help those clinics, as there's some new pieces to billing which they need some assistance with. And let's do the next slide. And again, happy to take any questions and receive any feedback on our 1115 dental waiver. One thing that I would also like to mention is that July 1st of this year, we're looking forward to completing our adult dental benefit, which again is just right around the corner. And so we're working hard on that, which will have additional dental services for adults qualifying for Nevada Medicaid. Thank you so much for your time.
Excellent. Any questions online or in person?
Question.
Yes.
Azraella Gravel, VP back member. I did have a question regarding the eligibility code of currently enrolled Medicaid members under or like termed diabetic. Do we have an idea of what the population is? The total population for our diabetic patients of Medicaid that we would be serving under this new demonstration waiver for diabetes?
The demonstration waiver is limited to those 11 participating clinics, so it's not a good measure of the entirety of the diabetic Medicaid population. I could get back to you and give you a specific number of those eligible. I don't have that at my fingertips right now.
Thank you, Dr. Benson.
So you have be accepted these member meetings if you would like to come off mute.
Hi, I just have a question regarding those patients who might be on the age of 64 if they still have Medicare and Medicaid instead of a managed care Medicare. Would they be eligible to continue the dental benefits beyond the age of 64?
It depends on the eligibility type for that Medicaid dual enrollment member. There are some sorts of enrollments that allow that to continue, and there's other sorts of enrollments that only pay for that Medicare yearly, not yearly, but their Medicare costs. And so it really depends on that eligibility category they're in. I hope that made sense.
Yes, it did. Thank you.
No other questions? With that, then we move on to agenda item 10, single preferred drug list. And I'd like to introduce Antonio Brown, Chief of Pharmacy with the Nevada Health Authority, to present their presentation on the single preferred drug list.
Thank you. Good afternoon, everyone. My name is Antonio Brown. I'm the Chief of Medicaid Pharmacy for the Division of Nevada Medicaid. And thank you for allowing me to provide an update on the Nevada Medicaid Single Preferred Drug List, or SPDL. This initiative is part of our ongoing efforts to streamline pharmacy services across the state. Next slide, please. And before I get into it, first, I just want to start with a little bit of context about the preferred drug list. As far as Nevada Medicaid pharmacy benefits, we use the list of covered outpatient drugs that are shown to have the same clinical effectiveness. This list helps guide providers to prescribe the preferred drugs within each therapeutic class rather than other options that work just as the same, but may be more costly. So what has changed? So since January 1st of 2026, Nevada Medicaid has transitioned to one unified preferred drug list. This means that all members, regardless of whether they are enrolled in a managed care organization or in fee-for-service, we will cover the same vast majority of medications. Currently, this includes all drugs that are available on the Nevada Medicaid PDL that covers any utilization management requirements like prior authorization and quantity limits, certain physician-administered drugs, and diabetic supplies. And as I just briefly mentioned, this impacts all Nevada Medicaid recipients, whether they're enrolled in a fee-for-service plan or a managed care organization. The main reason why we're doing this is to reduce the administrative burden for providers and our members, simplifying the prior authorization process, enhance the continuity of care, and ultimately improve the healthcare outcomes. Previous to the single preferred drug list, prescribers had to look at each of our plans' distinct preferred drug lists. So this aligns all of our Medicaid population into just one single unified list. Next slide, please. This is a quick look at our timeline here. We kicked off the stakeholder meetings in July of 2025. Operational technical planning sessions took place in Q3 of 2025, followed by user acceptance testing in Q4. CMS did approve our state plan amendment October 8 of 2025. And we went live on January 1st of 2026. This also commenced our legacy coverage phase. During this phase, we'll monitor very closely to maintain that continuity of care and ensure a smooth transition. Next slide, please. This is just more information about our legacy coverage phase, which runs again from January 1st through June 30th of 2026. And what do I mean when I say legacy coverage phase? So this means that for the first 6 initial months, all of our Medicaid members can continue to fill their current prescriptions without any change. The main purpose is to support the transition to our single preferred drug list and maintain that continuity of care. This allows providers and members to time to adjust when appropriate, and if necessary, switch to any of their preferred medications. Next slide, please. So for the most up-to-date preferred drug list, you can visit nvprimetherapeutics.com. /home. This additional link right here, you can find health plan information. And then, of course, if there's any questions from our members, providers, or any stakeholders, they can always email us directly at nvha.nv.gov. Next slide, please. I'd like to close by emphasizing how committed we are to ensuring that this transition has minimal impact and that the care continues without interruption. We've been using a variety of methods to communicate these changes to Nevada Medicaid providers, our recipients, but we also truly value your insight as advisory board, and we appreciate any advice that the board may have on any additional ways that we may reach individuals and then help them understand the transition and know where to find support if needed. So thank you so much for your time, your partnership, and attention to this important work, and I'm happy to take any questions.
Question. Grace Larkins, I'm the chair of the Beneficiary Advisory Council, for the record. My question is in this legacy coverage phase, when we, for reference, I have a very medically complex daughter. She's on a lot of prescription medications. So when when someone goes to pick up their prescription, and if it is something that is not going to be covered under that, that prescription drug list, I understand it will still be covered up until June 30, but will that individual be notified at that time by the pharmacy that, hey, this is going to be, this is not going to be covered soon? That way somebody can start working on appropriate replacements or substitutions.
Yeah, so thank you for that question. That is a great question. So as part of our efforts to communicate this transition, we have enabled many different methods. So the first one, most important one, is that the health plans in our point of sale system, so the pharmacy system, we have enabled notifications that alert the pharmacists and tell them this medication has now switched. You have until this period to switch the medication, so that they can notify those members. Also, what we're doing with our managed care plans is that we are running utilization reports. So any individual that is using currently a drug that may that is non-preferred as of January 1st, 2026, we're keeping an eye on them, and we're going to send individual notifications and also care coordination so that we may transition them into a new preferred product if appropriate.
Thank you. I'm looking at the list now on the link that was provided. If for example, anticonvulsants, the seizure medications, I see that the one medication which finally has ever worked for my daughter is on the non-preferred products. So I guess in that case, I sort of mentioned this at the back meeting, but I wasn't looking at the specifics. In fact, this is sort of a next gen seizure medication, Xcopri, that several families that I know of have had great success. So if that's on that non-preferred product, do we start preparing now to try to get an exception or an appeal? Because there can't really be a lapse, you know what I mean? And probably in a lot of different medications.
Yeah, definitely. So I think I would definitely advise you to have a conversation with your provider and to talk if a transition would be appropriate in your case. We do have a standard preferred drug list exemption criteria that's built into our policy. So if there is any, if your case meets one of those conditions that we have outlined on our Medicaid policy, then you would be allowed to continue on that non-preferred medication.
Okay, thank you.
We do have a couple of
Thank you for the
questions
questions.
online. I'll start off with MAG member Bill.
Yeah. Hi, guys. Billson for the record. I was just curious about the pre-authorization for Medicaid patients when we're filling their medications. So is that basically saying that once everything has been implemented and everything, will it essentially be quicker for patients to receive our medications? Without, having to wait, hours or even maybe a couple of days for Medicaid and our doctor to go back and forth?
Yeah, so thank you for the question. On the pharmacy benefit side, we are federally mandated to provide a response on the prior authorizations within 24 hours because it is a real-time benefit. So what we're doing with this project is we're not really changing the timeframes on the prior authorization process, but we are aligning those requirements in the clinical in the clinical requirements for all the plans. So instead of like the individuals who are enrolled in a managed care plan, and those are in fee for service, the same prior authorization criteria would apply for all of them.
Okay, thank you. Appreciate it.
Thank you.
Then we also have a question from member Phoenix.
Hi, John Phoenix for the record. Thank you for the presentation. I do have a question back to my comments. I'm not sure if you were part of the meeting at that point during the general comments, but I did raise the question and the concern about the limitations on hepatitis C medications with the requirement of patients having to be managed by by a specialist care. And that actually directly conflicts with the AASLD and the IDSA guidelines. So I'm wondering where that decision came from. Thank you.
Yeah, Mr. Phoenix, I did take note of your comment earlier, and I will take this back to the team. So in Nevada Medicaid, we do have 2 advisory boards that goes over our criteria. For this particular clinical requirement, it would be our DUR board who would have implemented this requirement. And we meet on a quarterly basis and with our prime vendor to create the clinical requirements that for any specific medications. I know that you had cited some concerns with the access to hepatitis C. I'm going to take this back to our team and review any of the guidance. And if we identify that there's an issue, we will bring it to the board.
Thank you, sir. And specifically for my clinical practice, I work in the substance use community. So we work very hard to keep them engaged in services. Having them to have to go to a second office for treatment is going to be a barrier because many of them are housing insecure, many of them are transportation insecure, and putting a requirement of some other person to go see when they can get everything in one place would be a huge barrier and a huge disservice to this marginalized community. So thank you for your time.
Thank you, Mr. Phoenix. I definitely take your comments, and as I mentioned, we'll take this back and review and follow if appropriate.
Hi, Azraella Gravel, Vice Chair of the MAC Council. I noticed that diabetic supplies were recently added to legislation to be covered under Medicaid. What are the methods enabled to alert pharmacists and providers of these newly added diabetic supplies? Thank you.
So I do want to mention that, and I don't remember specifically that bill number that you're referencing, but that only require coverage for so for Nevada Medicare, we do cover diabetic supplies to the pharmacy benefit. However, that specific bill that you're referencing does not apply to Nevada Medicaid plans or fee-for-service specifically. There hasn't been any changes other than aligning all of our coverage requirements and prior authorization and quantity limits with this single preferred drug list.
Thank you for clarifying.
Thank you.
you have any additional comments? Casey, I see you came off mute.
No additional comments or questions for agenda item 10 that I can see. Do you guys have any more before we move on?
No, unless these normal already.
Fantastic. Then we'll move on to agenda item number 11, which is our discussion on the statewide managed care. We want an opportunity to share feedback about the experience and observations of what went well and what challenges or barriers were encountered, as well as any suggestions for improvement or areas where additional support would have been beneficial. I'll jump in with some. As a provider, I noticed that some of the MCOs had some confusion on the continuity of care coverage. So I have to commend all of the announcements that I had heard. It made it very clear that there was this lovely continuity of care period for 6 months, which was fantastic. But I noticed that the web announcements had an emphasis on the rural providers, and I think that caused a little bit of confusion for some of the MCOs. And so we ended up with a lot of claims denied because they weren't adhering to the prior authorizations that we had from other MCOs prior to the changes. And from the provider standpoint, we are not aware of what prompted the beneficiary change amongst the MCOs. If that was, due to redistribution, if it's because they were in the rural areas. And so we weren't exactly able to differentiate those. So I liked that there's a continuity of care period, but we ended up with a lot of claims denied and some administrative burden trying to ensure that everyone was on the same page in order to reprocess and then secure payment for those claims.
Yeah, thank you, Casey, for raising that, and I appreciate you flagging it. You're right, there's obviously a lot of change, not only for folks entering managed care in the rurals, but folks in our urban communities that maybe transitioned, picked a new plan, or reassigned to a new plan, et cetera. So were you able to get to some clarification or some clarity there? Do you see value in us kind of continuing to hone any guidance there, or working with our managed care partners to clarify that? Would be happy to take any action if you feel like there's things still unresolved. But definitely taking your feedback to ensure that next time this happens, we're really clear on the urban component of it as well.
I think that the web announcement, just having some minorly tweaked wording would have sufficed that. I've seen a lot of this stuff be resolved on our side. And so it was just a little hectic there in January and February, but I know your team was extremely responsive in answering some of those questions. And I know that you had mentioned how many extreme volume of calls that they handled. So I really want to call them out for answering those emails and answering those calls and thank them for the hard work that they did on that. I've seen this continue to get better and better as the time has gone on. But a suggestion for 2030, 2031 for the next time would just be one consolidated web announcement that makes it clear continuity across all plans across the whole state would be great.
Thank you. I appreciate you noting that. I'll keep it in my 2031 notebook. No, we will absolutely take that back. And for the record here, there are care continuity provisions that apply whenever anyone transitions into managed care, regardless of whether it's the beginning of a contract period. It's just a bit longer. It's a 6-month period when it's this new contract cycle. Through just because we recognize this as a high volume. When someone transitions managed care organizations or into managed care, it's typically a 90-day care continuity period. And so we'll take this back with our team and just make sure the way we're talking about the more standard component is also clear, regardless of geographic region. So thank you, Casey, for that feedback. It's really helpful. And thank you for the kind words. I'm really glad to hear that we were able to get your questions answered right away.
Yes, of course. Thank you.
I'll make some comments. This is Dan from CareSource. I just want to echo Casey. I think that was great feedback, and I kind of echo Ann's comments during her administrator report update. I think from our perspective, we thought the launch went really well, successful. I think you alluded to some roadblocks along the way, but we've got through that, and I think that we're just very thankful, right? I think that we've all come together and be really gracious. I think a lot of flexibilities on everybody's side. But we've seen everything get better week over week, and I know we're in a special enrollment period right now. And we're still, hitting the ground running, but just very appreciative of everything and everyone being so welcoming of Care Source and the community. Yeah.
And I do see we have a hand raised. However, I just want to remind folks online that this discussion is for MAC members currently. For any members of the public, you can provide a public comment during the public comment section later in the agenda. Thank you.
Do we have any other questions from the MAC members online?
All right, hearing none, we're going to go on to agenda item number 12, which is the annual report. So the MAC must submit an annual report describing its activities, topics discussed, and its recommendations. The state will review the report and receive responses, recommended action.
And then drive all the way back to go to my PO box because I have documents that they keep calling about. So
Just a reminder, did everybody please take that songs and they're not talking?
So a section on the back will be included as well in the annual report. And so this is, this agenda item is to discuss and to provide comments from the members on. Do we have any comments, discussions, any thoughts on the annual report?
It's pretty blank.
Yes. So this is just the Highway Floor Associates for the record, part of the back and max support staff. We have this agenda item just to share what the annual report, the template looks like. We are hoping to, include recommendations at our next meeting, based off of what we got discussed since, we started these meetings back in August, and I believe the last one was in November. So at next meeting, in June, we will be bringing a fuller report, for your comments, suggestions, any additional recommendations you all have, and so forth.
All right, so more to come there, and we will expect a report in preparation for the June meeting.
Correct.
Understanding. Okay, excellent.
Okay.
No other comments. We'll move on to the next agenda item, Casey.
Excellent. Next, we're going to go over the MAC work plan. So the remainder of the meeting will be used to finalize the MAC work plan and provide any feedback or edits that will be taken from members and then incorporated directly into the work plan. Does anybody have immediate feedback or things that you want to add into the goals or objectives?
Ann Jensen here for the record. I just want to acknowledge I'm really excited to see a lot of feedback on increasing public awareness and communications. This is a real passion of mine and focus for this year. And I think there's a lot we can do to improve the way we communicate, where we communicate, and about what do we communicate. So I really want to ensure as we undergo a whole strategic communications effort internally at the health authority, that the way we're doing it aligns with your feedback. So if you all, as you review, have any questions or feedback on what we want to include here, I'd love to hear it. Otherwise, just adding my support and vote in favor of really centering a lot of those conversations, because I think that's a really important area for this group to give us some ideas and feedback on.
As for Ellen Gravel, to add on to Director Jensen's communication idea, I had mentioned in the back meeting that we should have an MCO flyer sent out to members. Just basically one-page summary of the manuals to help our members understand what kind of services they are provided.
It's a great idea. I'm curious, not put you on the spot on your first meeting. Let's have obviously member handbooks are a big component of it. But do you guys do more of like a simplified version of that with a list of benefits, or is that something that we should take back? obviously relevant to all our health plans, but since you're here, I would be curious.
Yeah, no, and this is that from care source. I think it's hard because when we talk about limiting to a one-page summary, there's so many different benefits. I think that we know this our members like to hear about, right? So in a particular meeting, somebody might want to hear about a VAB. In another meeting, somebody wants to hear about in lieu of services. So it's hard to summarize everything into one page unless it's something as simple as just putting like a QR code or a link to go onto like our website. But I don't know if that would actually meet the intent of what you're trying to do in terms of informing people about our specific MCO benefit.
I was thinking about health literacy for MCOs and what that could look like, and getting that information out to our members.
Are you imagining like a bullet point list?
Yeah, like a flyer, like a pamphlet, and then maybe do a broad overview. And then I don't know if I know each MCO has specialized services designed just for their MCO. And so it's like, hey, you're our new member, and you have all these new amenities that are available for you to consume and participate.
Yeah, so we do have something similar to what I believe you're envisioning. But we do that targeted to specific demographics, right?
Yeah.
So we have it towards like maternal health, if we know we're going to an event where that's the population we're going to be talking to. But let me think about a way to kind of do a more comprehensive one that is not going to be like, 8-point font and all just words right on the page, but that's probably not going to be effective either. Yeah.
No, I was thinking because the manual is,
Right.
I don't know if any member reads it, but we need to understand it kind of comprehensively to be able to get the best out of our care. So I was just making that as a point.
Grace Larkins for the record. I think I've done quite a bit of rural outreach and spoken with from the patient or family perspective. What I found folks confused about was I don't really clearly see what's the difference. What are the main things that I should be looking for if I'm going to choose one over the other? And I'm just saying this with the rurals with Silver Summit and CareSource, but I think also, with Northern Nevada, with each area, as we have those to choose from, it really would be nice to have an easy comparison point, as well as I think a motivator for many people probably would be the in-network providers. How many of their providers are, how many providers will they lose or gain? Is that provider list easily accessible, through them? And I do agree with Azraella. I feel like the, public facing information when it comes to health literacy, when we really want to think about having something available that really is clear and simple and kind of to a fifth grade reading level for certain just general public use, that would be, I think, really helpful.
I appreciate that. And I think that's also on us as a state because almost all the benefits our MCOs cover are required by our program, right? So all 5 MCOs will cover the exact same things because they're part of our program and it's standard benefits. So we could also just do a Medicaid one-pager that really lists, here's what the benefits are as part of our program. And we also have a one-pager that I think we can continue to tweak, but we can maybe share for feedback with this group in future meetings that shows the value-added benefits of all 5 MCOs so they can compare. The things that our MCOs have a little bit more design decisions on, we have a one-pager that summarizes what each of them look like, and then folks can look at that and see what may be more interesting to them or more applicable to their needs. But I really appreciate also your point on the provider directory. I know that's something that we're all committed to finding ways to continue to update and ensure it's accurate. I think in the marketing materials, I know our MCOs have staff on. That would be an important thing to continue to center is where making that link as accessible as possible. Although in the Medicaid Express project, we talked about this morning for everyone's benefit, the Medicaid online platform, where we're allowing folks to enroll and select shop for their MCO plan in the web platform through our exchange program. that would allow us to kind of highlight maybe what a plan's quality rating is, or the provider networks that they have access to. The goal is to make that experience even more user-friendly long-term, to do exactly what you're describing. So we may not be there in the current state, but that's definitely the goal, because we recognize any sort of plan decision and evaluation of options is complicated, and we want to make sure all the resources are available to people. So really appreciate that feedback.
And to bounce off of that, maybe since we are transitioning to a webpage, the Medicaid can have that flyer overview on their homepage, and then MCOs can have a specialized flyer on their homepage of basically all the benefits that the beneficiary has access to. So Medicaid could have the 5 MCOs summary, and then the specific MCO can have their flyer on their page and all those specializations that they offer.
Yeah. So Grace, thank you for sharing that. And I trust me, I hear your concern, especially on the provider directory piece. And I do hear what you're saying about maybe being able to understand what's going to be helpful for you to make a decision, right? Because now there's 5 players in the market racing, it's statewide. And it really is tailored, because one of the examples I used to like to use, but doesn't anymore, is depends on, like, for example, what kind of drugs do you take, right? Not issue here because we're on a single PDL now, or like, hey, it's going to be specific to your service. And so I think a lot of it is going to be able to just take advantage of being able to work directly with us, and then we, taking in all your feedback and everything, work directly with the state, because I think the directors and right, we want to make sure we are very supportive. We want to walk the line also, but we have to get our marketing materials approved and what's considered marketing versus education and all the boring stuff in the back end. But with that being said, I think we're here, and I think you reach out to any MCO, right? Any of my counterparts on the line, they're going to say the same thing, and we want to be able to support our members in making an informed decision. So.
That's great. Thank you for clarifying, and it sounds like we have a good direction. I think for me, it was really interesting. It took me attending I think it was the rural MCO meeting, and it was really interesting to learn about, for example, I believe he called it the hub and spoke model of CareSource, as opposed to the sort of looking at the difference, very different needs for individuals and families. And so for folks, as they're choosing to really kind of have that understanding even of that basic model, for my family, the hub and spoke model would actually work very well, because we need specialists that we know we need to go to a larger space, a larger school,
Facility.
go to the larger facilities, right? So, it's just sort of those basic, like, I guess that would probably be then on the Medicaid side, is to take all of those marketing materials and find what are the delineating, factors here that we can look at it in a comparative way.
Yeah, so the marketing materials, like I mentioned, that's the boring back end stuff that's really important. So those marketing materials will be brought to this committee, I believe in our June meeting. Yes. So in our June meeting for review and input by this committee. So the intention is every plan has leeway to design those in a way that they feel articulates best their values and their approach. And then this committee can provide feedback on whether that makes sense or resonates with what you all are seeing and experiencing, and have feedback you have. So look forward to that conversation next time as well.
Okay.
Yeah.
Thank you. Thank you.
ACS, you have your hand raised.
Perfect. In addition to everything that we've talked about on the MAC work plan, I would love for us to expand upon the goal for expanding the Medicaid provider network and make it a little bit more specific. I would love for us to get network adequacy reports so we can see exactly which workforce shortages are straining our system the most, and include all provider types. I don't know if this can be organized by geographical area, because I'm sure the needs in the urban areas are going to be very different than those in the rural areas, but at least that would give us some before and after data to compare. So when we look at the evaluation and reporting and deliverables, we can take a look at how many enrollees were at the time of the initial reports and how many were thereafter? Is that something that we could add in?
That's a wonderful suggestion. I appreciate it. So for everyone's benefit, network adequacy is a metric that our managed care regulations are held to as part of our contract. The state sets, this is the threshold that determines what your provider network must look like. And then we have an external quality review organization that evaluates whether those are met. And so there's a lot of nuance there in terms of what is published and reported publicly. So PC, let me take that back with our team and we'll confirm what components of that we could incorporate in this type of metric. I'm in full support of it. And I know that each of our plans are really focused on network management and would be committed to doing the same. And so what we can do is try to figure out the right metric that would be kind of apples comparison across all of our delivery systems. And I like the idea of using that as kind of a baseline and then progress tracker on this list.
That would be fantastic. Thank you so much. I appreciate that.
Yeah, absolutely. Thank you.
Azraella Gravel for the record. How often is the published provider network list updated for each MCO and for Medicaid? Is there a regulation for that or regulatory procedure to continue to have updated lists? What does that look like for members?
The good and complicated answer. Yes,
Sorry.
regulation on the federal side and the state side that kind of govern this. I think it may be helpful for us to kind of summarize all that and put it in writing for you.
Yeah.
So I don't want to misstate the source of some of the requirements, but I think we can all acknowledge, even when it's updated regularly, there's still nuances that make sense, right? It might not be clear whether the provider has actively seen Medicaid patients over the past year or whether they're accepting new patients. And so I'm actually going to have a conversation with our health plan presidents in a couple of days about how we can think together about how to improve that process. Because I think we can all recognize it's really challenging to get access to real-time data. It's not a Medicaid specific challenge, it's across the board. And that's because our providers' work is ever changing and there's a lot of administrative barriers they face. So the question is, how do we make it easier for our providers to keep us in the loop about their current status and then reflect that to our members. So this may be an excellent topic if folks are interested to add to the work plan in terms of how do we think through ways to make those network directories as valuable as possible to members and providers both. Because you raised something that we've heard consistently as feedback, which is why we're having this conversation.
I appreciate that. If we could add that to an agenda item, I think that's useful.
Yeah. I have a question. One thing I'd love to understand a little bit more is the intersection of mental health and Medicaid and how we are thinking about it at the state level. That might be a little bit broad, but that's an area that I think our state is extremely challenged in. Probably every state is extremely challenged in, but ours in particular. And I'd just like to understand kind of maybe a broader view of how we're thinking about it.
So it's a very important question, something that folks here, especially Sarah, like Weaver, shares a real passion for improving. We're 51st in the nation on a lot of mental health outcomes, and that's not acceptable. It's not where any of us want to be. So there's a lot we're doing, a ton of work we're doing on the behavioral health side that I'd love for us to be able to speak to, and then also can touch on the way that we work with all the other state agencies on this, because there's a lot of hands in the pie trying to help. And so definitely appreciate our recommendation and would be happy to cover that.
Kaylani, do you have your hand raised?
Yes, Kaylani Quinn for the record. I just wanted to circle back to what we spoke on with the back meeting as far as Nevada being 48 out of 50 with maternal health. And of course, 1 out of 2 births are covered by Medicaid. So Medicaid does hold a huge responsibility of helping to make birth safer for birthing people and postpartum people. So I would love for MAC, the Medicaid Advisory Board, to possibly meet with some nonprofits that work with Medicaid recipients that are pregnant and those other communities. So we have an idea of what that gap is, what the barrier is, and what is needing to be changed, because their experiences may be a little bit different from my experiences. We're working with, a lot of different families, and there's so many different nuances to birth. So I think it would be really beneficial for MAC to have a meeting, whether even if it's just like a virtual meeting or something with some of these organizations that are specifically for mental health, or I'm sorry, maternal health in Nevada.
Thank you, Kalani. I really appreciate that suggestion, and share your concern about where we're at, and I take that really seriously, given, to your point, half of the births in our state every year are paid for by Medicaid, meaning we have an ability to make change. So we had talked about this at our back meeting of having a really focused maternal health conversation, similar to what we had at the legislature a week and a half ago. I would love to do the same in the MAC if folks are interested. And I really appreciate your offer to incorporate some nonprofits feedback. I'd love to do that. And I think there's a lot I could learn from that. So definitely echo and support your recommendation there.
Yes, yeah, I can definitely help with providing some resources and maybe getting out some surveys and things like that I can do just to get that point of contact. And I think another recommendation I have would be, as far as the benefits that pregnant people are receiving and not a lot of people knowing about those benefits through Medicaid, if we could provide a trifold to providers, OBGYN offices, that they can give out to their Medicaid recipients that show the different plans and at least a few of the benefits, some of those basic benefits that pretty much all the plans cover. I think that would be really beneficial as kind of like a trifold that is in the offices that the recipients are going to.
Great idea, Kimberly. Yeah. I'm meeting with our public information officer tomorrow, so I'll add both of these, the kind of one pager on benefits as well as a maternal health specific flyer to our list. I think that would be excellent to go forward. And once we have drafts, we can bring it back to this. That would be really valuable. So thank you for that suggestion.
Of course. Thank you so much.
Azra Ella Gravel for the record. I believe that vaccinations should be a recommendation given the climate of our national health initiatives. I believe our health departments here at Northern Nevada does a great job for community health initiatives, and I would love a presentation regarding vaccinations and what services the health department provides through Medicaid.
Great idea. So vaccine coverage policy is part of our Medicaid program, and then the state has a number of vaccine initiatives as you're covering. Those are primarily led by our Department of Public and Behavioral Health, and so they're a state kind of agency partner. We're actually in their building right now, one of their buildings. So I like that suggestion of inviting them to come and bring some updates on their vaccine program.
I would love that. Thank you.
Grace Larkins for the record. Chairman Awala, I really like that you brought up mental health. And I think, we talk a lot about behavioral health and I think it would be worthy of a future agenda item to really just kind of hunker down and take a look at where Nevada is with mental health and what kind of, solutions or initiatives have been discussed and maybe that we may be working toward. And just, I think it would be great to have would be another one where it would be nice to have, maybe some guest experts. I don't know. I wanted to propose it as a future agenda item for mental health. And Administrator Jensen, I really do sympathize with the potential of trying to keep up with the in-network provider lists. I know that, the Nevada Center for Excellence in Disabilities, we have with several partners over the years tried to keep, because we provide resources to families all the time, trying to keep some kind of an updated provider list that reflects if they're taking patients, and what insurance coverage they accept, And at one point, the medical home portal was supposed to be a really good space for that. That was funded through Title V through the state. And even then, with the medical home portal, having a full staff with their only job, I mean, a main part of that staff was to try to keep those updated. And it's not just, you know, not that this isn't new information to anybody, but it is such a complicated, it's such a complicated picture when it's not just, you know, the MCO itself chooses to, you know, be enrolled with or not, but on the providers, if they choose to stop taking Medicaid at any given time, I mean, that's going to change daily within, and so to keep track of that many, it kind of seems like an insurmountable task, but it sounds like you all are talking about solutions, but how do you even get them all on the same page? If you have, like, say, the Medicaid Express, like that you were mentioning. So if there could be centralized databases on things, I don't know if, you know, if a change was made by one of the MCOs, could that automatically be made within, you know, a master database that it's good to hear you're working on it, but I can't imagine how at all.
No, I appreciate that. It's incredibly complicated, but yeah, more we can do. And also there's probably gonna be more we can clarify our rights to providers as well in terms of them kind of notifying us on items. So I think it's kind of how do we ensure we're asking for the right information once we have it, reflecting it in a central place. So thank you for echoing that in my totally agree.
But how long is a provider enrollment term typically?
Depends on the provider type. But typically it's between 3 and 5 years before that revalidation process occurs for the actual enrollment of the Medicaid program, but it varies. So not always as timely as what we're looking for here. Yeah.
Just a quick comment to that, Grace, and I guess kind of in addition to what Kilani was saying, right? So we've heard for weeks now, right, about Director Weeks and Administrator Jensen talk about, you know, we spend $13 billion a year, yet we're like last or near last in these 4 different categories. And so a lot of the concerns that you guys raised are things that we do here as MCO too. And for example, so what you have brought up on being able to update like the provider directory to one MCO does like an all MCO do it. That actually came up in the Clark County Access collaboration that we had to do. And so it's good that this forum is one of the ways that you guys are able to share this feedback for us, because when we hear it, you know, we can work with the state as well to help push that direction. So just, you know, really appreciative of you guys being open and being able to share all that with us. And it's something that we do take to heart.
Great, thank you for sharing.
Any other suggestions for the work plan?
I think that was a great idea that she brought up about bringing people into the meetings, people who are working directly with these communities that we're serving and Medicaid recipients. I think now more than ever, we need to be directly working with the community. And I think if we at least bring in people maybe once a year to speak on the concerns, whether it's mental health or maternal health, and these specific needs that are not being met by Medicaid and what things can be done different, I think that would be really helpful, even if it's just a 15 or 20-minute presentation. I think that can be really helpful with what we can look forward to changing in the future.
Great, thank you. Before we move on to the next agenda item, you have made some real-time changes to the work plan. We're gonna go ahead and share our screen. That way everyone can do the changes. And ideally, we would like to finalize this work plan during today's meeting. So again, opening the floor to any other feedback that the MAC may have. Again, we just want to make sure we encompass all of your recommended suggestions and changes that we discussed during the last 30 or minute or so.
So based off of comments, we've added some maternal health presentation from Nevada Medicaid and a request to include the organizations with maternal health focus as an activity. And a deliverable from that would be to provide recommendations on maternal health initiatives for Nevada Medicaid, as well as the discussion on mental health or future discussion on mental health, to then provide recommendations on mental health initiatives for Nevada Medicaid. Any other thoughts or comments on that? Good.
I was just hoping that we could have a presentation on the community health initiatives on vaccinations from the health department. Either Southern Nevada or Northern Nevada, and even rural health departments could be included.
Yeah, I think our state Department of Public and Behavioral Health maybe can give a data across statewide focus, and we can call out the context for the local ones if there's any questions.
Yeah, I would love that.
Yeah. Presentation on vaccination, but state vaccination programs.
Grace Larkins for the record. Just to touch back on what Casey was talking about, the how to expand the Medicaid provider network, which I think is an amazing goal. So just to clarify, Nahevi, I saw a little bit further up in the draft there, when we talk about that conduct provider satisfaction and barrier surveys. So is that something that still needs to be developed? Does that need to be developed by the MAC? And then that would be used, I would imagine, to inform how we would give what recommendations we would give in order to expand that provider network?
Yeah, so I think this is something that we talked about in the Beneficiary Advisory Council meeting after talking about the committee creating a survey. Again, I just want to remind the committee that the purposes of this committee is to provide recommendations to the state Medicaid agency on services, programs, and implementation of those different programs. And so I think as far as like feasibility and including this type, something similar to this is going back and seeing what current provider satisfaction or barrier surveys we have as an agency, bring those to this meeting, review those, and then therefore provide recommendations on how we can improve those surveys, additional questions we can include, and then therefore that can kind of help inform some data that we can probably bring back at a future meeting as well. Does that sound okay there? And I've made some changes to the language there to reflect that as well.
And Kimberly, I see you have your hand up.
Hi, good afternoon. Kim Abed. I am the administrator over DCFS. I just wanted to kind of hark back to the conversation about wanting presentations about mental health and having that on the agenda. My request or suggestion would be that we dig into that a little further to be a little more specific about what about mental health, right? Mental health is a very broad issue. We have the transformation, which is working specifically around children's mental health, but the Medicaid population obviously also covers adults. So are we talking children? Are we talking adults? Are we talking both? And then what about mental health? As was stated, we're 51st in the country. So we know there's a lot of issues we have in our communities and in our state, and there's a lot of room for improvement. But we also have various bodies and committees and groups that work on this issue on a regular basis. So I don't want us, I want us to be mindful of what our mission is and what our role is on this committee, and that we're not kind of veering into things that other people are spending considerable time and energy on. And so I think narrowing that focus to understand what information about mental health is helpful to this body in order to carry out our mission and our goals.
Yeah, I might comment on that. Rahul Mediwala, I brought up the question. My particular interest is on initiatives driven by Medicaid in the state. So that's my focus, not on what is Nevada Medicaid doing from an initiative standpoint? What are their priorities? That's what I'd like to understand.
So then instead, maybe for the activity, the Nevada Medicaid can provide a presentation on current priorities and initiatives around mental health.
That's correct. And then I'd like this body to give input on that.
Grace Larkins for the record. Thank you, Chairman Awala. That was really interesting. I think you hit it on the head. Kimberly, I'm sorry that I can't see her last name, but those initiatives that you mentioned, if there those groups, those whatever committees or work groups are out there right now happening within the health authority that are related to mental health, I would love to know just even what those are, right? So that we could see what they are working on, not trying to reinvent the wheel, but what's in progress or on the plate already.
I would second that or third that. I know that there's a lot of support in it, and especially the adult focus. I think that there's a really great children's behavioral health transformation project that is very robust. And I know that's a part of Administrator Jensen's reports at the beginning, and that is one of the top 3 priorities for the state. I would be really interested to see this committee have a focus in what's being done for adult mental health, especially since some of those beneficiaries might be impacted by the federal regulations for HR 1 as those come down the pipe. So I would really like to hear kind of those childless adult population and how they might be impacted.
We'd like to incorporate that piece into the work plan to focus on adult mental health, or still keep it just mental health?
I think that's reasonable.
Yes, adult.
Yeah, that's right.
Azraella Gravel for the record. I would like to point out there's some limitations for outpatient services for pediatric patients. As of now, 1 through 5 years old children do not have access to mental services through Medicaid or even private insurance. I think that's a huge issue in Nevada that we're facing. My family is facing that at a psychiatric level and at a therapeutic level. For inpatient hospital services, there are assessments and surveys given to pediatric patients as soon as they're admitted. The jargon related to those regulated by Medicaid confuse the children, frankly, and they might not give appropriate response if the jargon is out of their jargon. If the jargon's out of their literacy comprehension level. So I would love if we could kind of speak about that in the Medicaid initiatives and priorities, if we could address that as well. Both inpatient and outpatient services in the hospital setting and also in a provider setting for pediatric patients. Yeah, under 5, we don't have any services for our kids. So I'm like, it's very frustrating. Frustrating, yes.
Want to briefly just look through the work plan before we move on?
I think we've looked at it. Are there any comments on the work plan? Any additions in addition to what we've already talked about? I know we've talked about it extensively. A motion?
I have one clarifying question for the presentation on state vaccination programs. Again, I want to remind provide recommendations to the state Medicaid program. So as for the deliverables, is it to provide recommendations on how, if for Nevada Medicaid to have some sort of like vaccination initiatives?
I think it's general feedback, isn't it? Is that what we were recommending?
So the health department does a really good incentive to let established patients know when they're due. So their program here at Northern Nevada is wonderful. I'm not sure about Southern Nevada or rural health state health departments and their impacts that Medicaid or Medicaid impacts on their health departments. But if we could have a presentation on the community health initiatives on vaccinations through our health departments and maybe have somebody present from a health department on those topics, that's what I'm recommending.
Yeah, so maybe as it relates to giving recommendations to the Medicaid program, we can also include a short update from our team on Medicaid's vaccination coverage policy.
Yeah.
I think the recommendations, what I hear you really focus on is the actual delivery of vaccines, and that falls outside the realm of Medicaid, which is I think what you're raising is there's not necessarily anything to give us advice on. But I definitely welcome input on ways we can communicate with providers clearly on our vaccine coverage policy or some other component of it. I think, is that kind of what you're raising is like, what's the Medicaid recommendation as it relates to those programs and those fall outside of our. That makes sense. Do you have any thoughts there?
So when my children were under Medicaid, I know that Medicaid paid for the health department's vaccination of my children.
Yep.
And so if there's any like health initiatives or promotion or wellness initiatives from Medicaid to promote vaccinations, I think that's where I was going towards.
Yeah. So maybe a presentation on Medicaid's like vaccination policy and what types of maybe initiatives or incentives we provide for getting vaccinated, and then the deliverables can be provide further recommendations on how we can promote those incentives.
Yeah.
Maybe.
Thank you.
Sorry, just having a thought there.
Yeah.
That's awesome. I
guess I can see how, I think maybe I'm connecting that this is definitely a hot button issue right now. That again, I guess I can, how does it relate with Medicaid directly on what we would want to be able to give input on, and we want to touch that issue? I mean, I don't know.
I see where you're coming from. If I might, just thought my thought is we could provide initiatives in directing our personal thoughts as clinicians, as members, right? To say, we would like to see a more focus on pertussis and measles or whatever. Is that reasonable?
Yeah, I think any recommendation is reasonable. We welcome it. I think from our perspective, our vaccine policy, we believe is very clear and consistent with state and federal law and has not changed. And so I think what you're calling out is reference to like community engagement and population health strategy, which is excellent. That just falls within our colleagues at Department of Public and Behavioral Health. That's where we really lean on their support. They run all of our public health and population health programs in the state. So I think the tension or the kind of the partnership we have here is a little bit is what's coming into play here. We welcome recommendations, but we're not the ones that can act, right? And so how do we get that to the right folks? So I do think that we spoke about our managed care organizations sometimes have incentives related to vaccination. And so that may be one angle where we do have a little bit more levers at play. But I think keeping it more focused on the kind of connection and the way that we maybe incentivize it is best, as opposed to our policy, which we don't anticipate changing. And then maybe we can ask our colleagues at Department of Public and Behavioral Health to recommend forums or input on their population health strategy and vaccines. Maybe that's so that I really appreciate your passion for how to be communicating about it. And they are the ones that are really thinking about how to do it. And I want to make sure your feedback gets to them. Does that make sense?
Appreciate that.
Okay, so I just added that as an activity to present presentation on Medicaid's current vaccination policy and initiatives offered through Medicaid. And as a deliverable, provide recommendations on how Nevada Medicaid can promote incentives for vaccination.
Thank you.
And with that, I think we should, is there a motion to approve the work plan as it's revised?
Yes. Yes, I'd like to call for a motion to approve.
Second. All in favor, say aye.
Aye.
Any opposed?
Aye.
Hearing no opposition, then motion passes. All right. A lot of robust discussion. That's what I like. And we've set the agenda. All right. That moves us to agenda item 15, which is the roundtable discussion. This agenda item is to address any matters that were not addressed in the meeting. Potential future agenda items, et cetera, although we covered quite a lot of that here. So I leave this open. Please raise your hand and we'll call on you.
Do you have any comments or suggestions from members online? I see a hand raised here in the room. Grace?
Of course, sorry. Grace Marcus for the record. I was just kind of reflecting on what stands out to me in dealing with on a personal and professional level of families seeking healthcare navigation, and behind this problem and behind the deeper you go, right, it always comes back to policy related things, systems related things. And oftentimes the workforce, right? I know that the healthcare workforce, the lack of healthcare workforce in Nevada is at the heart of so much, it seems like. And I believe in the Rural Health Transformation Program, there's some workforce development initiatives. I know that I believe I'd heard that any of like tuition reimbursement is off the table. We're on that, but I guess I would just be curious if, and maybe it's not a Nevada Medicaid, maybe it's not a Nevada Medicaid duty, right? Maybe it falls in other places, but just curious how I see in our work plan, we talk about increasing that provider network, but that would be if we have the providers in order to contract with. So I'm just curious if there's any discussion or movement around healthcare workforce, or in any ways that we would be able to have any impact on or contribute to. I don't know.
There's a ton of work on provider workforce across the health authority. I think you're right to point out Medicaid's levers are more limited. Of course, there's a lot we can do in the realm of addressing administrative barriers and concerns providers may have in terms of access or getting enrolled with Medicaid or billing Medicaid. And the network adequacy piece that Casey mentions is a great angle that we can take. You're right, there's a ton of work with the Rural Health Transformation Grant, as well as the Sharp grants, which is a Casey program for provider workforce initiatives. Those fall outside the realm of Medicaid, but I think will hopefully help bring more providers to the state and attract them to stay. And so both of those in our graduate medical education program, there's $16 million funding for that. So each of those has their own steering committees and advisories. I think that gets to some of your point. Like each of these topics has numerous forums for it, but I think that's always a very agenda item. If you would like to have updates from those developers on how to be involved in those forums, I'm sure we could. Members are interested. Do you guys know that?
No, I don't. Once more, I think it is. There are a lot of different forums for this. We can get that information. I don't know if this is to be discussed here. If I'm suggesting that we should discuss it here, or if we can provide that link.
Yeah, I think the Nevada Health Authority, like you said, there's other initiatives, other groups going in many of these areas that we're talking about. And it's such a deep dive to really sort through all of that. But this is part of that process, so I appreciate it.
Other discussion ones, online or in person? Casey?
I was just going to say, having a synopsis of what the Nevada Health Authority is looking at in terms of workforce development might be nice in terms of looking at network adequacy, what it is that the MAC can influence and what we can't. So if there is a way to make that short and sweet for an agenda item, I would be in favor of it.
Yeah, absolutely.
Thank you.
Azraella, on record, in lapse of Medicaid coverage, adoption services are not provided for medically necessary abortions, including sexual assault, as an alternative option. I would like to open a discussion on these matters.
The discussion on the Medicaid coverage policy.
Yeah, potentially looking at sexual assault instead of opting for an abortion, having paid for option by Medicaid for adoption services to be included in medically necessary procedures.
Yeah, I think we can include this as a topic if it's helpful to go over our current policy. And we'll note in this area, there's a lot of state laws and federal laws that dictate our coverage policy. And so any changes to that would need to go through a legislative forum. We don't have the authority to make those changes on our end. I think if there's any suggestions that you have related to additional Medicaid coverage, I think the challenge, we always have to get approval from CMS on what things we pay for, and those have to be tied to medical services, right? And so I think what you're describing is a really important connection to other services we have in our state that may not fall into the parameters of CMS to pay for as a service. So maybe we can think through as part of the maternal health discussion topic, which I know is on the list as well. Wherever there's kind of community resources and our colleagues, Administrator Abbott's DCFS team that has adoption assistance resources, we can find ways to kind of make those clear and connect folks to those programs.
Even if it's like a referral that's paid for those services in the community, I would suggest it be brought up in the legislative forum.
Yeah, absolutely. So we cannot pay for referrals themselves, but we can pay for the medical services that may initiate those referrals. So I think we can think through those nuances there. And just for the benefit of the whole group related to any topic here, the state and Medicaid cannot bring forward legislative items ourselves beyond what's in our budget or any kind of statute corrections. And so I would definitely recommend, there's numerous ways to kind of get on the radar of various bill draft requests and be part of that legislative process through other forums. And I would encourage folks to explore that. I just want to be really clear on what our role is as an executive branch agency. We are here to advise on how bills would be implemented within the Medicaid program, but we can't bring any forward or take a position on it. So definitely appreciate there's a lot of change that can happen within our program, but there's a lot of change that needs to happen outside of it as well, given the statutory regulations.
Any further online or in person? If not, we'll move on to the next agenda item, which is a public comment period. And I know that there's a number of people online. So can we get those public comments?
Yes, we'll start off with D. Biggs. You see your hand up?
Thank you. For the record, my name is Deanna Yates. I'm with the Nevada Therapy Alliance. I just wanted to second the suggestion made by Nisha in the prior public comment period for the rate parity between provider type 34 and provider type 20 for outpatient therapy services. Right now, outpatient speech, physical, and occupational therapy providers enrolled under provider type 34 are reimbursed at a considerably lower rate than the same providers linked under provider type 20. Our request is to pay the same rate for the same licensed providers, the same qualifications, delivering the same service. Thank you.
Thank you for the public comment. Do we have any other public comments online? If so, please raise your hands. You can be called on. Brandon, I see your hand is raised.
Hi, Brandon Ford here, Best Practices Nevada, former president of United Providers Mental Health Nonprofit. So I've worked with a lot of the different therapists and mental health clinicians in the community. I helped a lot of them with the struggles that they have with Medicaid, be it credentialing, enrollments, getting in MCOs, claims, all kinds of issues, right? And I really want to try to contribute and get that information and some of my feedback to the committee. I know I'm not a member, so I'm not able to really participate in these meetings, but I hear a lot of stuff and I want to say something about this and that and so many things. If I can put it all in writing, is there a place that I can submit this and the committee would review my notes and feedback and suggestions? Is that allowed?
Hi, Brandon, the Hy-Vee Forest Associates for the record. I'm part of the MAC PAC support staff here. If you would like to provide some written comment, you can email us at community and providers at nbha.nb.gov. And we can circle back with you. Jonathan is going to also go ahead and throw that in the chat for you to send that information to.
That'd be great. Thank you so much.
Thank you for your comment. Any other comments that we have?
So thanks for the record. I would say that sounds like really great feedback. You know, when we talk about on our work plan related to expanding that provider network, getting that kind of direct provider input. So that would be interesting to see that. I was just trying to find the name of the bill, which bill it was that was related to the verification of providers at provider enrollment of like identity verification that we discussed in the past. Yeah. So on that one, I had mentioned that a provider that I recently spoke with who has been enrolled with, contracted with Medicaid for a couple of decades, was recently, I think these, as outlined in AB 36, this, it's 315. Yeah, 315. That electronic identity verification system was required of them, and the director was uncomfortable with putting a picture of her driver's license and a video as well onto the portal. And I thank you very much, Administrator Jensen, for offering to speak with them and help me to convey the message that it's a secure network. But also, it got me thinking that this director is, so when we have certain members of the population who are maybe not so tech savvy, who she really was like, can I please just come in person and you can see me and I'll show you my things? Like, is there really no option to do that anymore? And that does seem like a barrier to me if there's just not any other option other than, I don't know. I guess my question is there the potential for somebody to get verified in person?
I appreciate the question. I will have to follow up with you on our team on what the alternative options exist, if any, on that piece. I'll just note our provider enrollment process is really complicated because there's a lot of really extensive federal regulation regarding this, and then current administration is really focused on this area right now. And so we have to ensure that we're following all their guidance. And so I appreciate we don't want to create unnecessary barriers, and I recognize access to technology and tech literacy can be a real challenge. And so finding ways to best support folks as we can within regulation is always the goal. So we can follow up with our provider enrollment team to identify what other options exist. But I think the other piece is how can we help folks navigate that process and support them in accessing what they need to be able to do that. So, I don't have a clear answer for you on that now, but we can follow up, and I'm happy to work with the director that you mentioned on any of their particular questions.
Right. Well, I wonder if beyond this particular director, there might be other individuals who find themselves concerned about the identity theft piece that seems to has been kind of rampant in certain areas. So maybe it's a little bit about the messaging as she's filling out this, going through this process, she was unable to find somebody who would ensure her that it was a secure network. So if it is, and sounds like it is, then maybe that could be clearly front and center stated some way.
Yeah, I appreciate that feedback. Messaging is the most important part of anything we do, so I'll take that back to our team to make sure we keep communicating that and kind of the bounds and definition of that secure network. Thank you. Yeah.
I would like to make a public comment on Ivy Flores Rosilas for the record. I just want to throw out there that we are currently recruiting for Beneficiary Advisory Council as well as our Medicaid Advisory Committee. We will be having some positions opening later this year with some terms coming to end in June. So we have 2 Medicaid recipient positions available on the back currently, as well as or will be available soon, as well as a current or former Medicaid recipient or persons with direct experience supporting a recipient of Medicaid. And then on the Medicaid Advisory Committee, we will have the following positions open: representing a member of a profession in the field of healthcare who is familiar with the needs of persons of low income, the resources required for their care and availability of those resources, representing a person who holds a license to practice dentistry in the state, a person who holds a license to practice medicine in the state and is certified by the Board of Medical Examiners in a medical specialty, a person who holds a certificate of registration as a pharmacist in the state, and an administrator of a hospital or a clinic for healthcare, as well as 2 back member positions that also serve on the MAC. And so if you are interested in applying for those positions, you can visit our website. Jonathan will be putting that in the chat. You could also email us at communityandprovider@nvha.nv.gov. And yeah, we hope to get some applications in there and get some new faces. Thank you.
Excellent comment. Thank you.
BF.
Yeah, yes, Brandon, we see you have your hand up.
Brandon, if you are speaking, we can't hear you. I'm not sure if you still have a public comment.
I'm sorry. Yes, I was saying thank you for letting us know about the announcement. I definitely will be applying. I appreciate that. But there was a popular question that I'm receiving from a lot of providers right now in the behavioral health, and it was about the rates. You know, I keep getting it over and over. Are there any updates on SPA 25-0013, I think, or 16 maybe was tied into it as well? But it was about the behavioral health rates and getting the increase as of January 1st, 2025. Is there any updates to tell them?
Yeah, okay. Thanks, Brandon. Happy to end public comment on a positive note. We shared in our Children's Behavioral Health Working Group last week before last, that we just did receive approval on that SPA, which is excellent news. We're making our final updates in our system now to account for that change. We'll be providing a web announcement to all providers of what that recycle process and billing guidance will look like. But great news is that we got the BMS approval, and we're seeing a lot of things move on that end. So look forward to that being part of our billing systems very soon. Thank you.
Wow, great news. Thank you so much. I'm sure they will be excited.
All right, with the end of agenda item 16, we come to the last agenda item, which is adjournment. I'd like to officially adjourn the meeting at 3:13 p.m. on March 3rd.
Well,
thank you.
Thank you. Thank you.
Thank
you.
Thank you.
Thank you, guys.
Thanks all. Appreciate you joining us.
Great, a lot of great stuff.
Yeah. I'm so glad I'm so close for you. Find ways to do this again. You guys heard Dr. Medewell's office is right there. Yeah. I'm jealous. I'm just a little farther up the road, but we're close to it. So.
Not